end as well. So with that, I just want to say welcome to Dr. Elvin Geng, who is our speaker for today. Dr. Elvin Geng is a professor of medicine in the Division of Infectious Diseases and the director of the Center for Dissemination and Implementation at the Institute for Public Health here at Washington University. He earned his MD and his MPH degrees and completed a residency in internal medicine at Columbia University, and subsequently completed postdoctoral training in infectious diseases at Rockefeller University and the University of California in San Francisco. Using the lens of implementation science, he conducts research to optimize the use of evidence-based interventions in the public health response to HIV. In particular, he is interested in strategies to influence the behavior of systems, healthcare workers, and communities. And current topics of ongoing investigation involve observational research to assess engagement in HIV treatment with partners, strengthening patient-centeredness in public health, and adaptive interventions. He collaborates closely with colleagues, non-governmental organizations, and public health agencies in Kenya, Zambia, Uganda, and as well here in the United States. So without further ado, please help me welcome Dr. Elvin Geng. I know it's a little harder to do in a virtual environment, but please help me welcome him, and he's going to talk to us about implementation in lessons learned from this current pandemic. So thank you, and Dr. Geng, over to you.
Okay, great. So Angela, I'm getting a little bit of a echo. Okay, I think that's gone. So thanks for having me. A real pleasure to be here on this cold winter but sunny day. So, I have, maybe 30, 40, 45 minutes of some comments prepared, but eager to make this, if possible, a dialogue. And so, we'll try to keep one eye on the chat, and also, if somebody's feeling inspired, please do call out and interrupt. I thought I would spend a little bit of time today just talking a little bit about kind of, provisional lessons and insights about research, public health, and implementation research that have come to mind for me during the last year. And I wish I had more sort of time to do this, because once I started thinking about it, it did seem like there were lots of lessons worth reflecting on. So this is just scratching the surface, and I put these sort of thoughts out there mostly to see if they can trigger further discussion and conversation. So let me share the screen here. Okay, so this is my now 7-year-old. She is learning about infectious diseases, maybe a little sooner than her curriculum would have normally offered it. But we live in the time of COVID. I got her this comic book about science comics. This one is the Plagues, the microscopic battlefield. And so now she's quite familiar with, SARS-CoV-2. We'll have to wait a few years for 9. But, C. diff, Streptococcus pneumoniae, and other things. So I think it's emblematic of where we've all gone this last year, whether or not you were sort of interested in infectious diseases before. They've kind of gotten to be part of our social and general public fabric and discussion. So just some, lessons and reflections. So COVID-19 has been a great disruptor, right? There's a million ways to kind of slice and dice, I think, our experiences over the last year, but for sure it has been a disruptor and has changed things and has changed the game. I think that it has placed researchers, and in particular public health researchers and in implementation researchers, in a sort of uncomfortable space because of the rapidity by which the epidemic has unfolded, by the prominence of implementation issues, and by the seemingly enormous sort of societal and other sort of dimensions of the problems that we face. I do think that, you know, it's led to an opportunity for some reflection there. Here are some basically a few lessons that I will try to elaborate on that have come to mind for me. There surely are many others. First is that implementation science is important, and I'm not sure that the scientific environment has yet given it as much sort of shrift as it might need for us to mount a scientific response. Certainly there's been a tremendous amount of interest in science, right? The development of vaccines, the development of drugs, but we do need an implementation research agenda to that's commensurate in magnitude, scope, and investments. I think COVID has brought home a lesson that the world needs to learn, not just about COVID, but almost of all of our problems. What affects one is the problem of all. This is true for COVID. This is true for climate change. This is true for myriad other problems that the planet faces. I would say that one of the lessons for science and public health is that you know, the rapidity of our response is probably a weakness. We have systems to do a lot of things. Some of them work better than others, but one thing that I don't think we have prepared the groundwork for is rapidity, and rapidity is sort of the name of the game when it comes to COVID and other similar problems. I'm going to reflect a little bit on what the role of science and academics is for technical support. I'm going to maybe argue that you know, science is sort of only as good as the social fabric that supports it. We can do science as researchers, but the implications and what sort of comes of it depends not so much on the science. Well, it certainly does depend on the science, but it also depends on where we are as a society and the sort of issues of justice and equity and things that form the background for what good society can do with science. And then last, I will say that I think pandemics are fundamentally social, and then I'll touch on the idea of data as power. So nearly a year ago, I do remember being an infectious disease sort of doc, feeling a little bit like this kid in Jurassic Park, because, you know, I mean, for weeks, every day, wake up, you know, read the news and see that the infection was continuing to spread around the world. And you knew it was coming for a while, even before it did. And I felt like, to some extent, you know, maybe a little bit like this movie. So, you know, looking to find ways to mitigate, to hide, to defend, and other methods. I want to say a few words about my activities, because this is an opportunity. I'm going to reflect a little bit on my experiences, which you know, are obviously not necessarily you know, the most informative, but do provide the background for the arguments that I make. So during the last year, I have worked closely with academic collaborators to produce academic research. I've worked closely with some sort of actors at the state level to understand and project and think about I think, technical aspects of understanding the epidemic to inform sort of policy directions. I've worked with a group here at IPH to do sort of surveys and epidemiologic work at the county level. I've interacted with the regional task force, mostly on the modeling end of things, but through a number of work groups. And then I've been involved in sort of some investigator-led research. Okay, so first, it does bear saying that from an implementation research perspective, for COVID, we do have scientific knowledge and evidence-based understanding of the infection, the pandemic, and things to do about it, even before we had new technologies to deal with it, which we do now. This is a generic representation of sort of almost any infection, and can be applied to understand transmission dynamics of almost any infection. People or other organisms can get infected. There's usually a period between being infected and the onset of infectiousness. That's called the latent period. There is a period between infection and symptom onset. That's the incubation period. There is a start and an end of infectiousness for most things, sort of not all, some are indefinite. That's the infectious period. And then there's a period of clinical illness. And these kinds of intervals can be characterized for different infections and used to understand, I think, basically the dynamics of an epidemic. And as I've said before, infectious diseases, it's not exactly like the science of physics or chemistry, where, if you put 1 aliquot of this and 2 aliquots of that, you will get that for sure. But at the same time, we do understand the general behavior of infectious diseases. And this is a simplified equation, but does capture quite a bit. It's the reproductive number. It's like, for any given case, how many other cases will that case give rise to? And the reproduction number, when one case is introduced to a totally susceptible population, is called the R naught, or the and that term probably has become like a household term at this point. But it's really a function of 3 things. So sort of, the number of infections per contact, the number of contacts per time, and the sort of duration, sort of time per infection. And on the green are sort of behavioral or conceptual components of this, right? So infections per contact is sort of an intrinsic feature, transmissibility. Contacts per time is a function of mixing and population density, and time per infection is yet determined by other things. These parameters also map to different mitigation strategies, right? So decreasing the probability of infection per contact, there's certain things we can do for that. Medications might decrease your viral load, et cetera. Contacts per time can be changed by social or physical distancing. And then the time per effective infection can be altered by practice such as, isolation, hospitalization, et cetera. And so these types of relationships can be captured or modeled with sort of compartmental models of epidemics, which break a population into different compartments and then define the relationships between those different compartments through equations. And under various assumptions, these things can give you some understanding of how an epidemic will behave under certain conditions. And so, we have, everybody's heard the term flatten the curve at this point, right? And so the idea is that, by changing some of those parameters you saw in the previous equation, you will change the movement of people from susceptible to infected, and et cetera, and also therefore change the number or the density of any people falling into any of those compartments at any given time. We have known about this for a long time. None of this is new. This is a paper from JAMA, but it is a paper of deaths from the influenza epidemic in 1918, and a number of different plots that show the relationship between various public health activities that relate to those parameters. So the top left, you have public health response time, which is how soon the cities acted. And then, for example, the bottom right, you have the total number of days of non-pharmaceutical interventions. But each of these things is related in a pretty remarkably correlated way to things like the time to the first peak of excess deaths, the total deaths per population, the excess deaths per population, et cetera. And you can see that even back then, different places took different levels of sort of urgency to the distancing activities, and it changed sort of outcomes pretty remarkably. We have, of course, within a year, developed even more evidence-based interventions. We now have vaccines. We have treatments, medications that minimize sort of bad outcomes when somebody is infected. And we have quite a number of them, in fact, and we have a number of vaccines. So we have a whole new toolbox of evidence-based interventions. So, so with all of these things, a few sort of things about the science have come to mind. And one of them, I would say, rapidity sort of as an implementation outcome, and not just maybe a service delivery one, is of importance in pandemics. So let me bring home maybe what rapidity means and how fast an epidemic changes. So this is a projection of the number of hospitalizations in a place with a population of St. Louis, assuming something like 10 cases in the hospital around March 15th, 2020, which was about true, and then with a reproductive number of around 3. So people have estimated various reproductive numbers for SARS-CoV-2, and 3 is a reasonable estimate. That the red bar is approximately the number of, let's say, available hospital beds. Okay, let's say 2,500. That might be generous. I'm not sure. But if you look at this curve, like any exponential process, time is critical, right? And if you imagine like a health system trying their best to create hospital beds and stuff like that, you can only move that red bar up and down a little bit. Like you could never move that bar to like 10,000. Like there's no way we could get 10,000 hospital beds. There's no way you could even get 5,000, right? You can move it up 10%, 20%, maybe if you really push the envelope. There's other folks on this call who are more expert than that than me. But the bottom line is that red line is relatively unfixable. So in a 14-day period, between April 15th and May 1st, you would go from a situation where on April 15th, you thought you were in good shape. You're like, we got way more beds than people who need hospitalizations. We are in fine shape. By May 1st, you would be underwater, and you would be so far underwater that it would be like a horrible situation, right? And so this is the nature of infectious disease epidemics with things like SARS-CoV-2 with relatively short doubling times. It all depends on sort of like, because the severity occurs over very short time frames, the response also has to occur over very short time frames. It's actually the opposite in some ways that I think of as HIV, which is the disease I've spent most of my life working on, which occurs over relatively long time frames, right? So nothing that you do for HIV in one moment in time is going to affect the epidemic. Things that you do have to be sustained to change the epidemic course. This is the opposite. If you don't do it now, it's too late. That's the nature of the beast here. I think I think one lesson from that, I don't know what the answer is, but I think we need to take a page out of disaster preparedness in implementation research and think a little bit about how to incorporate preparedness to act rapidly, far in advance of any anticipated or unanticipated sort of pandemic event. There are certain techniques around sort of scenario planning, around coordination that can be put in place, and consensus building about collective action. I mean, I think that in our society, we do need collective action. Collective action can't be imposed from above, but what can we do to get to a place where we can put some of the pieces of the puzzle together for collective action before April 15th, when you only have 10 days to do so? Don't know what those are, but perhaps worth thinking about. One possibility is the idea of extending surveillance and surveillance mechanisms to behavioral things in addition to biological things, right? So we all understand when you have an infection, you got to know the number of people who tested positive, you got to know the number of people hospitalized, you got to know the number of people who died, and we accept that we need surveillance on clinical things, but I'm not sure that we likewise believe that we need surveillance or surveillance mechanisms for sort of behavioral dimensions and drivers of behaviors. A piece of research that my colleague Ingrid Eschen-Wilson has done and is sort of in peer review right now is a choice experiment looking at preferences in the population for different distancing policies. So for those of you who haven't encountered a choice experiment before, it is a technique that comes from sort of economics and marketing, and presumes that humans make decisions to maximize their utility, which is sort of our happiness or satisfaction, and that we can't have everything we want. So we are always making trade-offs. We're always making decisions about the package of things that maximizes our utility or our happiness, given that we can't have everything all the time. Since utilities are not something you can draw some blood and run a test on, and you can't even ask, like you can't say to somebody, like if somebody says, how many units is this, like how many units of happiness is this worth to you? You wouldn't be able to give them an answer. So what a choice experiment does is that it tries to draw out it tries to quantify an individual's preferences by asking them to choose between two versions of a good or service. Could be a car, could be a restaurant, or it could be a set of, in this case, policies around social distancing. And in each time you ask them to choose between the two, you change the levels of the attributes that compose that good or service. So by asking them to choose repeatedly over time, you can discern which attributes of that good or service are worth the most to that person and to that population. And you can tell how much of something else the population would be willing to give up in order to get that thing. So in this particular experiment, people were provided with two counties with different social distancing policies. And they were asked, which one would you choose? And the attributes that were altered were your risk of infection, how much income loss you would have, whether or not schools were open, whether or not outdoor venues were open, whether or not large gatherings were allowed, and how long the duration of distancing would be. In this experiment, which reached about several thousand people in Missouri, it turns out that it looks like there are sort of four groups of sort of like behavioral phenotypes. So the top left, the x-axis here is happiness, essentially. If you go to the right, happy, left, unhappy. And in about half of people, you can see that their sort of psychological profile is characterized by a strong aversion to the risk of infection. So risk of infection, 30% versus 5%, very unhappy. And it outweighs the other things that they want. The top right are risk balancers. These people are unhappy about the prospect of getting infected, but they are happy. They want schools to be open, outdoor venues to be open, social venues to be open. And so they're balancing between these two things, whereas the first group doesn't really care about those things. They just have thrown all their eggs in the basket of eliminating risk. On the bottom left, there's this altruistic group who seems to not care that much about the risk of infection, but does feel nevertheless that things should be shut down and should be shut down for some time. And then finally, about 15% of people on the right here, you can see that they don't really feel, the prospect of an infection doesn't really bother them that much. It doesn't go to the left that much, but they have strong feelings about opening everything, opening schools, opening outdoor venues, social venues, large gatherings. And so these different audience segments might inform the kinds of sort of communications and policies that could be directed at different segments of the population. Do we need methods for quantifying and investments in quantifying sort of, or the ability to quantify things like this, out of the gates? Maybe that's some food for thought. Okay. Number two, I think COVID has posed some challenges for scientific processes. Where are we with science and COVID? Well, publication is too slow. Preprint, too much garbage. Everybody's complaining about like stuff on preprint that's invalid, like half-baked projects that are not totally ready for prime time. But on the other hand, the world needs knowledge now. And one thing that I've learned from sort of weekly calls with policymakers at the state and local level, more than multiple calls a week, is that the world needs knowledge now. And what is urgent today is often irrelevant tomorrow. And in fact, the day after tomorrow becomes urgent again. So the urgent questions like turn on a dime. And so what kind of a scientific process kind of like accommodates or acknowledges this kind of need for knowledge, right? Like, I mean, it could be that there isn't one, but let's try to imagine what it would look like if there were. I don't know what that would look like, but if I can advance the slide, which I seem to be somehow unable to do. Let's see, how did... Okay, sorry, let me try again. Okay, in trying to imagine what science could do, I wonder if we can, if it is possible to sort of like reconceive of science as a living process, right? So on the one hand, the need to be iterative and improve, but on the other hand, sort of like removing the constraints of one-time publishing and one-time peer review, and removing the idea that publications are sort of a snapshot in time. So is there in the digital world a way that scientific products can be made public, but their provisional nature can be made clear, and the public could understand the extent to which it's in a provisional process, en route to greater and greater confidence? Because because something like that would acknowledge that science does evolve, and the truth is that anybody who's published sort of a paper knows is that it is an arbitrary point in where you in your scientific progress with that particular problem, right? Like if you're thinking hard about something, you analyze data and then you publish, but you continue to think about it and work on that problem, and a year later, 2 years later, your views on some of that stuff might be different. So I'm not sure what a living process would look like, but it would be interesting to try and imagine what kind of like structure would allow sort of knowledge to diffuse quickly while acknowledging the provisional nature of that knowledge. Okay. Number three, revisit the role of the academic, sort of refining the concept of scholarship. This is a paper by Doug Luke, who, if I'm very fortunate, is on this call, but is a prominent member of our faculty that I'm sure many of you know. But published a paper a couple of years ago called sort of the translational science benefits model, for a framework for assessing the sort of wider benefits of clinical and translational sciences. And this sort of concept has given me some framing for some of the activities that I've spent a lot of time doing in the last year, which I've spent very little time sort of publishing on. And so for example, it's sort of thinking about the societal value or the potential value of what's being done versus kind of like what the sort of where that coincides and overlaps with publication, and then where perhaps it doesn't. So one of the issues that you'll recall the first slide I showed, where there's like velociraptors chasing a kid in Jurassic Park. At the beginning of the epidemic to COVID, one of the things that I and some colleagues sort of noted was that for a number of reasons, local decisions matter, right? We did not have a national strategy to COVID that was uniform everywhere. And so decisions ended up being made by localities. And in some places, like Missouri, a lot of those decisions were made by very, very relatively small sort of units of the education system or the healthcare system. Like, and local decisions do matter. I mean, I think, from H1N1 and other places, people did like natural experiments to show that, even if school districts were contiguous and overlapping in one suburb, the decisions to close the schools or not by one school district changed outcomes in those communities compared to the other ones, even though they were right next to each other. So local decisions do matter. But to the extent that an epidemic was coming, local agencies do not always have the capacity to develop essentially compartmental models of the epidemic. Lots of groups, this one out of the UK, but also at Harvard and Columbia, are mathematical modelers of the COVID epidemic, and they do this kind of stuff for a living. I mean, they modeled influenza before, and then they converted to modeling COVID, but and they produce very, very sophisticated compartmental mathematical models or other, and made projections like this. Like this was Neil Ferguson's early projections that predicted 2.2 million deaths in the US, 500,000 in Great Britain, under a certain set of conditions, right? He's widely panned for saying that this is how many people would die. He's just saying this is how many people would die under essentially conditions of not doing anything. But for the point I'm trying to make here is that, like, any given locality or space or state or city is going to have an epidemic experience that's vastly different from the national mean, right? And so mathematical models that are produced to try to get national estimates are going to be of limited informativeness for local policymakers. Here's another one, from IHME. This was, I believe, another, at any rate, another mathematical model at the macroscopic level, leaving local policymakers with relatively few sort of resources from that point of view to use. So I think one of the things that I worked on with some colleagues here is this idea of a sort of a global to local modeling, not a model, but a modeling platform. And let me just sort of cut to the chase here. These are my colleagues in California and elsewhere. But but the idea was to create a mathematical model, a compartmental mathematical model that was good enough to be serviceable, not the most sophisticated model in the world, but accepts inputs about epidemic conditions, population size, age structure, policy dates, and hypothesized policy effect sizes from local policy makers and public health actors in order to produce, essentially mass produce, if that was sort of the pipe dream, locally relevant projections of the COVID epidemic. Let me just, this was an early version of it in R. It's on the model, the platform remains on GitHub. It's publicly available and can be used. You know, in later versions, let me just show, you know, later versions, this is an older version now, but basically, like, if you are an informed local public health user, you could put in your best guess as to what you think these these numbers, these parameters should be, and you could specify the amount of certainty that you have about them. So you could say, you know, I think my best guess, and I think it's 60% right, is that the basic reproductive number is 3.5. I'm willing to entertain reproductive numbers down to 2.5 and up to 4.5. And that's based on both literature and your interpretation of local events. And then it's sort of calibrated with data from your local environment, right? So early on in March, we had very little data. We had hospitalizations, and we had like 5 days of hospitalizations, that's it. As time went on, you had more, but you can take that data and put it in so that you can essentially use your sort of priors, and then use the actual data to get sort of posterior estimates of the probability of each one of those sort of parameters of interest, and it sort of in R, and essentially accepts a file and spits out a series of projections. Here's an example of early sort of model outputs from this. So this is sort of like, I would say that, like, this was an interesting experience because we did spend quite a bit of time doing it, and we thought a lot about usability. And you know, the sort of idea of forming, storming, norming, and performing, like every time you have a team. So around March of last year, we had a team, including my colleagues that, you know, from California, and then, you know, people from like the tech world, and then mathematicians and whatnot. And the biggest challenge was how to design, I think, or one of the biggest challenges was, one of the big topics of discussion was kind of like how to design this thing, right? And the more sophisticated you make it, the quote unquote more right it is, but the less usable it is. And the idea was that, like, we thought we wanted people in the real world to use it. And so what we ended up with was actually, I mean, it's interesting. It's actually used by various local, state level and other public health folks. Some of it is occurring without, like, my knowledge of it at all, and much of it sort of is occurring. People have, you know, programmed like extensions to it and stuff like that. So I think from on one hand, it's been interesting and successful, and, you know, public health agencies in California are using it also. The governor's office, you know, the work we did with them, and Abby Barker, if she's on the call, we used it. The task force also. But you know, I don't know if it was totally successful. I sort of think it could be used more widely, but it was never published. It's on GitHub, and like sort of shepherding its wider use was just, you know, something the pandemic just unfolded too quickly. So, but it did make me think a little bit about kind of like, you know, what I did as an academic and the importance. Like, I felt like this is probably one of the better things I've done in my life, but I can't point to any. I can't point to, at least yet, any publication that has evidence of that. But yeah, and we used it to do hospital level projections across Missouri and things like that, and, you know, it basically has functioned fairly reasonably accurately over the last year. Okay. Number four, and this goes back to one of the points that I was going to make here. Pandemics will find our social failings. So this is I don't usually use Chinese in my sort of slide decks, but this is there's a discussion in Chinese political philosophy from thousands of years ago about something called tianzai or renhuo, and so tianzai are natural disasters, right? Floods, earthquakes, pandemics, but renhuo are disasters created by people, mismanagement, blah blah blah. Poor handling of a situation, inability to recognize, and this Han Fei's thought that basically natural disasters, tianzai, are oftentimes not that bad. They're either made really bad or not by the way that they're handled by people. And so so the emphasis was kind of like on how people handle this, because number one, it's avoidable. If you create a disaster, it's avoidable. And number two, even under natural disasters, what we do to respond to it will determine how bad the quote unquote natural disaster is. So, I think the COVID pandemic really brought home the fact that our structural inequalities and structural racism have led to a long-standing sort of social injustices and disparities that COVID sort of instantly honed in on, right? And I think has been a topic of much both, has been a topic of a lot of national um, conversation since the beginning of the epidemic. One thing that has informed my own scientific practice, and in which I sort of found to be important for the science around COVID in our in a societal setting, is informed by Camera Phyllis Jones's thought and work. And one of the things that she has said, um, and she's well known for being sort of a scholar of the effects of racism on health outcomes, is that, like, as investigators, we should vigorously investigate the basis of observed race-associated differences in health outcomes. So we, no matter what health outcome you pick in the United States, it's often the case that there will be race-based differences in those outcomes. And but what's an anti-racist a sort of scholarly practice? It's not. She has lots of recommendations here for that, but one of them is to not just look at those observations, but rather investigate their mechanisms, and investigate their mechanisms in order to dismantle them. And so some of the work in our group has been informed by trying to understand the mechanisms by which the COVID epidemic has more severely affected the African American population, because I think there are many mechanisms by which it did, but one of them, which is under the control of the health system, has to do with the distribution of services. So this is from Alok Modi, who's faculty here in infectious diseases, and he's published a couple of papers on this topic. But here is, if you look at just the top here, on the y-axis you have sort of tests per diagnosed case in the white population, and on the, sorry, that's the y-axis. The x-axis is tests per diagnosed case in the Black population. And then each square or circle or shape represents a geographic location, a zip code. And the size of the dot represents the severity of the COVID epidemic in that location, meaning the overall sort of number of tests given. And then the colors represent the sort of racial ethnic makeup of the community. And you can see that in almost sort of every in every community, the rate of testing, the number of tests done per positive result is greater in whites than in African Americans. You know, suggesting kind of like a broad difference in access or accessing testing. What's important also about this is that that difference exists even whether or not the zip code is mostly white or mostly African American, and persists even so is not explained, for example, by geography. Let me skip ahead to this. This is another of Dr. Modi's analyses. I'll draw your attention to the curve on the left. It is a Lorenz curve. Lorenz curves were used and have been used by economists to quantify income disparities. So on the x-axis is usually sort of proportion of a population, and on the y-axis is the population sort of wealth, right? So a perfectly straight line would imply that 50% of the population holds 50% of the wealth, which is a totally equal society. Everybody has the same amount of wealth. A very bendy curve is a very unequal society in terms of wealth, because a small fraction of the population, you know, between say 80 and 100, hold a large proportion of the wealth. If you've seen Lorenz curves of American society, Brazilian society, South African society, you will see that these are like Lorenz curves that are quite bendy. Like a small number of people hold a large proportion of the wealth in this country. So this is an analogous. So in order to try and understand sort of the distribution or the unequal distribution of testing, on the left here is a plot of the cumulative proportion of hospitalized cases, indicating the severity by zip, and then on the y-axis is the cumulative proportion of tests. So and then the colors indicate the proportion or the fraction of the zip code that is African American. And so you can see on the bottom left that this was done a few months ago, that in general, the sort of darker blue are the sort of areas where you know, the African American population is less, and in those places the contribution of the test to the total is greater than the contribution of the cases to the total, or the severe cases to the total, indicating sort of an unequal distribution of testing, using disease severity hospitalizations as a benchmark. Maybe I'll end with a couple of observations that might not be all that optimistic. So science is only as good as the social fabric. So this is data that a postdoc is working on, but these are publicly available data from the Census Bureau, which have been released, where they call a representative sample of Americans and they ask them about vaccine hesitancy. And there is a remarkable correlation between the percent voting Republican in the 2020 election and the fraction with expressing either definitive or probable hesitancy to vaccine. There's almost no overlap between these dots, and so you know, I think that we live in remarkably sort of polarized times in terms of beliefs and political persuasion, but you know, I think as expected, it spills over into the value proposition that science can make for society. I'm optimistic that we will overcome and be able to address some issues around vaccine hesitancy. I'm not optimistic that we will get all the way there, but nevertheless, you can see that Americans are remarkably varied in their positions on on the vaccine, and a lot of that is correlated with the political persuasion of the state. Okay, looks like I'm almost out of time, but let me just say that lessons learned from COVID, I think, will carry forward into the future. And we need to probably contemplate a new, maybe normal. So if you look back at the 20th century, there have been a number of different global novel infectious epidemics, pandemics. And taken on a biological timescale, this is all one moment in time, right? Like it's maybe 30 or 40 years since HIV, but from a biological point of view, that it's all within 1 second. So the fact that there are numerous pathogens, some of them novel, some of them spreading in novel ways, from an infectious disease point of view, makes us sort of maybe revisit the notion that that this is an abnormal event and that we will get back to normal, but rather maybe we need to think about the emergence of pandemics as essentially a new normal. And from that point of view, the conditions that make it possible. So Judea Pearl has a interesting monograph on what starts a fire, right? So if you light a match and you start a fire, we all think that it's the match that started the fire. So we all think, that SARS-CoV-2 is the match that started this fire. But of course, you have to have oxygen in the room for that fire to have been started. No oxygen, you got a match, you're never going to get that match to burn. So the oxygen in the room here is the connectedness of like the global population. And in the instant connectivity of the global population is the backdrop that makes sort of the emergence of new infections sort of one step away from a global pandemic. And that's the nature of society today. And that's probably not going to change. Okay. So I guess in conclusion, just a few provisional thoughts about sort of some things that came to my mind as I reflected on the last year. COVID-19 poses challenges to public health, science, and society. These challenges remain even if COVID-19 goes away. None of those things, from my sort of thoughts about the need for science to be living versus the social injustices that exist, none of those things sort of go away if COVID-19 goes away. But maybe we can't completely count on that either. So I think we're out of time here, pretty close to being out of time. I probably went on a little longer than I intended, but hopefully that was, if not informative, at least somewhat entertaining. And so, yeah, welcome any sort of thoughts here.
Yeah, thank you so much, Dr. Geng. That was very informative, very great talk, and I think it gives us a lot to think about the different lessons that you've kind of put together about what it means post-COVID for some of these things. And I think we kind of are out of time. There is a couple of comments in the chat saying thank you and some interesting points there. If anyone has any one burning question or one last thought that you really want to present to Dr. Geng, please take yourself off mute and jump in now. Anyone? No? Okay, well, thank you so much. We know exactly, well, we probably don't know exactly. I think we understand how busy you are, so we thank you for your time today. And I really appreciate you spending this hour with us and giving us these insights. So with that, Malcolm, yes, please.
Were actually questions. A couple of the comments were actually questions. They weren't just saying thank you. A couple of them were actually questions.
Great. Oh, okay. Thank you. Yes, and unfortunately, I think we are out of time to answer those. But Thank you again, Dr. Geng, for your time, and we appreciate that you spent the time with us. And with that, we will sign off, and thank you everyone for attending this installment of Public Health Speaker Series. Thanks so much. Well, thank you. Thank you again.
Yeah, thanks.